This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you. My name's Bill Shearer. I work at Monash Health. So by way of introduction to Monash Health, it's a lot of numbers. What it means is we're big, particularly by Victorian standards. That makes it sometimes hard to get moving, but once we get going, we're also very hard to stop. So if we're doing the right thing, we keep doing it no matter what. If we start to do the wrong thing, we can also have problems with that. So Dandenong Hospital, which is part of Monash Health, was an early adopter of medical emergency teams. We participated in both the MERIT study and the National Observation Chart pilot studies, and one of our campuses was a control hospital, which Ken Hillman refers to as polluting the MERIT study. That's because they weren't going to be shown up by Dandenong and have worse results for their patients, so they had a pseudo-MET. So we've been in the game for a while. So I was thinking about this talk. I thought, what are we trying to achieve? And I've pulled these two definitions. The first one is from the current welcome page of the International Society for Rapid Response Systems, who are our hosts today. And rapid response systems are interventions designed to detect and respond to acute changes in patient. Fair enough. I actually like the second definition because I have a role in management and funding in healthcare as well. Patients needing a rapid response system intervention are suddenly critically ill and have a mismatch of resources to needs, and I'm going to come back to that resources to needs thing. But this is what the whole game is about. So what does success look like? Well, it looks like we have a MET team, a medical emergency team. We have MET calls. We have missed MET calls, and of late I'm going to talk about missed local escalation opportunities. We have unnecessary METs, and we work very hard to reduce those. There's two sorts of unnecessary METs. The people who shouldn't get a MET, and we've done a lot of work looking at goals of care to make sure that we establish goals of care for all our patients within 24 hours of admission so that they don't get somebody calling a MET or another code when it's not appropriate. And a new, more recent phenomena, which is the patients who don't need the MET team. We also measure multiple METs and ICU admissions, but the prime outcome of the medical emergency team is to reduce the number of in-hospital cardiac arrests and subsequent deaths. That's where we all started emotionally, and that remains the prime measure that we have to look to delivering on. So I hope these figures are clear. This is how we're going at the moment. I pulled the data off our intranet yesterday. The two queries are because the number under September 15 was 83, which was a bit out of whack, and I didn't have time to check it, and the February number for ICU admissions is not yet available. What this shows is a relatively stable system. We sit somewhere between 13 and 15 MET calls per 1,000 SEPs. We sit somewhere between 0.5 and 0.3 and 0.7 for cardiac arrests per 1,000 SEPs, and we're pretty tough on that. So our code team goes to everybody who is not an inpatient and doesn't have a MET call but has a code. The cardiac arrest team goes. We clean that data up and make sure that they are inpatients who've had an arrest and they're not in ICU, CCU, the operating theatre or the emergency department. So that's our rate, and it's pretty stable. And our rate for missed METs is also pretty stable. So the things that are working for us, we don't have arguments about the triggers for escalation. We've been using the same triggers pretty much for nearly 20 years. We fiddle around occasionally and talk about it, but we don't do too much. The team always comes and nearly always keeps themselves nice. So I was at a previous session this morning where people were talking about bad behaviours from the medical emergency team. Never been a feature of our organisation. We've always been very lucky in that the medical emergency teams have been welcome from day one. They've done their job appropriately and with professional courtesy, and if they have something to complain about, they do it in an appropriate fashion. They rarely fail to achieve an improvement or more appropriate management, so we still spend a lot of MET on getting the home team to come and actually have a look at their patient and make them, not for resuscitation, not for meds, or actually have a conversation with the patients about what their appropriate goals of care is. The home teams are almost always welcoming, and sometimes they're too welcoming. We've had physicians doing their daily ward round, take a look at a patient, decide they were crook, and ask their registrar to call the Met. We counsel them. So what's not working? So sometimes we have missed Met calls, and we'd been going for quite some time when we noticed that we were having missed Met calls in our most mature part of our organisation, and we were worried about that because sometimes the outcomes were pretty bad. Missed Met calls are because we didn't see the problem or we ignored the problem. Increasingly, we're worried about occasions where we didn't hear the problem, and I'm very interested to hear what Imogen says about family escalation. We don't do that very well. We don't do that as well as we could. And now we're worried about wrong Met calls. So always been worried about patients who shouldn't get the Met, who should have had more clear conversations with their treating team. Now we're worrying about patients who don't need a Met. So we didn't see the problem. What observations and how frequent were they? So we put a lot of effort into making sure that everybody understood what observations were required in all circumstances throughout the length and breadth of our organisation, from our mental health facilities to our subacute facilities to our community facilities through to our most acute wards. We spent a lot of time thinking about what we do when things are not quite right and not quite wrong, and we've been very lucky in that our medical emergency teams have always responded to that clinician concern parameter with a great deal of respect. So it has stayed on our lists. Sometimes we've ignored the problem, we didn't understand the significance, and sometimes we didn't think what we were seeing was significant for a particular patient. So this is what we did about it. We had an aggregate review of all our mismets, which is we sat down and looked at 15 cases and looked at the features of all those 15 cases to try and find some common themes. And there was, by that stage, an existing body of literature which told us what we should be looking for. Unfortunately, the usual issues quoted in that literature did not appear to be our problem. So people love our Met teams. So nobody said, oh, they're such pigs. So we went on to have focus groups with our staff and to undertake some staff surveys and some staff meetings. We did a human factors and a sociological examination of the resultant data. The human factors examination we had conducted in association with a group of experts. We knew going in it wasn't going to return us an enormous amount. We expected that we weren't going to get an enormous return on, which is why we brought the sociological examination in. Sociological examination ran to 12,000 pages, cost us a fortune to get it analysed and brought down to a few pages. But in the end, what we got down to was this idea of we don't do it that way in our area. And that became the basis for a whole pile of local area negotiations. I say negotiations because they were negotiations. We basically opened the conversation with, you can do it our way, or you can do it your way, but there are certain things you will do, and we negotiated from there. What we came up with was customised local area plans for management and escalation of deteriorating patients. We trialled those. Now, I've said here they showed no degradation in performance. That's a little unfair, but trying to be really fair. That's the best we could say. There was a statistical improvement, a statistically significant improvement in a couple of small areas, but in particular our quality and safety surveys of staff improved significantly. Our missed mets and cardiac arrests and most things didn't change. We developed generic principles from that, which we extended across the whole health service. At about the same time, we were a pilot hospital for the national track and trigger observation charts, and the mandatory introduction of those track and trigger charts paralleled our local response work. So this was the local standardised response. So we have standardised observation triggers, we have standardised responses. We developed a category called clinical review, and then we had the category which was MET or code. What does a detailed local response look like? So we taught people first aid. We said, if you think someone's crook, do something about it. So sit them up, give them a little bit of oxygen, repeat the obs. We taught them local escalation rules, and we negotiated those local escalation rules. The first one was non-negotiable, that is, the nurse in charge of the shift needs to be told. The others were negotiable only about time. So the resident medical staff needed to be told within 15 minutes. The registrar needed to be told within half an hour of the patient becoming unstable. And we were very clear about what that response should be and what should happen, so that there had to be a review, not somebody over the phone changing the MET criteria. The actions had to be documented, and the reportable OBS, if they were changed, that was very strict rules. We also spent a lot of time as an organisation looking at common local area problems. So one of the ones that we negotiated on was pancreatitis. The gastroenterologist said, if we report everybody who's got a pulse rate with pancreatitis with a pulse rate over 130, your MET team will move into our ward. We're happy about that, but you probably won't be. So those local area problems and management were negotiated. We also spent a lot of time looking at all of hospital problems. So we developed some training for simple things like short of breath, pain, decreased urine output, very simple stuff which we spread out amongst all our junior staff. What we got was a template for decision-making, treatment and escalation of clinical concern before it becomes unmanageable and avoids a mismatch of resources to needs. How's that working for us? Not bad. So we do an observation chart study on one day between 1100 and 1300 hours. We have multiple teams which go out with a very specific task, looking at the OBS charts for the first 24 hours and following up by reading through the health record if that's indicated. These have been just another day, as indicated by the number of METs, mismets and codes on those days. The initial study, we looked at 650 acute hospital observation charts. Approximately 4% of those charts had a missed MET opportunity. This did not include people who had criteria for a MET and went on to have a MET. It was just an opportunity to call a MET that was missed. One MET call was made by the reviewers who looked at the chart and said, oh my goodness gracious me, and hit the buzzer. The second study a few years later looked for both missed MET and missed local response opportunities. This time we did 1,200 observation charts. We included maternity for the first time. We included paediatrics and we included adult mental health, which was a fascinating exercise. Thank you. What we found was that our missed MET rate had dropped from 4% to 0.4%. But our rates of lost opportunities for local escalation had actually gone through the roof. They'd gone up to 4%. So had we just changed the problem? So we're no longer missing METs, we're just missing local escalation opportunities. Probably not. Our dose of MET is stable and has been for a number of years. So that's the number of METs per SEPS. Our missed MET rate continues to decrease. Our in-hospital cardiac arrest rate has continued to decrease, but is probably plateauing, which is a whole new game for us. So perhaps we've got a new problem. Perhaps what we're doing is we have changed the missed MET to a missed local response opportunity. More importantly and more optimistically, what we're actually might be seeing is successful local responses so that we're not having MET calls to those patients, or a new type of wasted MET, that is, less of those people who shouldn't have a MET and more of those people who don't actually need a MET. And if so, why is that happening? So I'm going to talk about decision-making and escalation. So I love this stuff. It's really, really dense and it can make your head hurt. So I'm an anaesthetist by trade, so I know a lot about how I make decisions, intuitively and brilliantly, usually, based on enormous experience and a whole pile of things. But it's actually interesting to actually think about how we make, as humans, make decisions. I've just pulled out a couple of things here, but the best place to go for, if you want to get your head hurt, if you want to get a headache, Harvard Business Review has an enormous, famous medical and philosophical journal, the Harvard Business Review, has an enormous amount of work on decision making. If you get through the profit and loss column and get to the actual guts of the material, it's actually really solid, interesting stuff. There is also a very good paper in Anesthesiology, Volume 120, Number 1, I cannot remember the name of the authors, which looks at anesthesiology decision making. Essentially, it comes down to there are a few models for how we make decisions. Usually it's one on the basis of expected value. I've mentioned Henry Simon and Kahneman there. Just to mention cognitive shortcuts, and because both of them got Nobel Prizes for the work they did on decision making. Heuristics are very interesting and come into how we make decisions and how we make decisions whether to call a Met, not to call a Met. And then there's bias. So lots of the reasons why we don't call Met have been attributed to bias. Lots of the reasons why we're now calling Met when we don't need to do it are actually also attributed to particularly experienced bias. And that brings us to escalation. So the trouble with escalation is that it becomes an endpoint in itself because we make the decision to escalate too easy, or the alternative, that is, looking at your patient, taking another set of obs, doing the first aid, talking to your boss, finding the resident, finding the registrar, and actually coming up with a coherent management plan is too hard. And that might be where we need to work. So escalation is not an answer, it's just one of the treatments that a deteriorating patient should receive. It does not remove the responsibility to treat, and escalation isn't always escalation. So we have a phenomenon which we see in a lot of our adverse events, which we call horizontal escalation, which is what the Australians would refer to as phone a friend. So you ring your mate and the pair of you have no idea what's going on, but you talk about it and you both feel better. There's also no value-add escalation. That's when you ring the surgical registrar and they say, it's not a surgical problem, that's no value-add. And then there's excess value-add escalation where you actually get an ICU consultant comes down and just stays nice because they really didn't need to be there. So all treatments have side effects. If you consider steroids, we know that steroids can cause steroid suppression. So consider the rapid response systems. They are life-saving in hospitals. If you don't believe that, you wouldn't be in this room. Are there side effects? I think there are. Unnecessary activations and wasted activations are side effects. I think that represents cognitive suppression. We're making it too hard for people to think by putting too many rules around it. We're making it too easy for them not to think, just by pressing the big red Met button. It's easier to escalate than make an appropriate clinical decision, and as escalation occurs without treatment, there is more potential for error. So this come back to a matching of need and resources. So this is Emma. Emma is the daughter of a friend of mine who I work with, and I have permission by both Emma and her parents, mother's a very senior nurse, to use this picture. Emma is 14 years old. Emma is 6'4" high. Emma plays basketball for Victoria and may well play for Australia if she continues to grow. Emma had a Met call from the pre-admission area because her heart rate was 45 beats per minute. So this is resources being wasted where there is no need. And just by the way, Emma's mum and dad, who both run marathons, don't need a Met call because their heart rate's 45 as well. Thank you very much.